Good morning, everyone. Thank you for the invitation to this conference. I'm Xiaoming He from Shanghai Children's Medical Center. On behalf of Professor Zhang, I will present our center's experience in choosing surgical strategies for DORV, focusing particularly on the management of DORV with non-congenital VSD. DORV has a spank of autonomies based on VSD location and the presence of primary stenosis. It's primarily classified for 4 types: VSD type, TLF type, TGA type, and the NC-VSD type. The VSD and the TLF type are the most common, while NC-VSD type about 15% to 20% of cases. The surgical approach of clinical outcomes very significant with autonomy, and the NC-VSD type is the primary factor influencing the rate of biventricular repair. Our goal in managing DORV is to achieve biventricular repair in selected patients, aiming for the better long-term quality of life. For this purpose, we have made significant progress. In global, for instance, a French study of 393 patients showed the biventricular repair rate was only 53% with a 16% mortality before 20 years. But this improved to 99% with only 1% mortality after 2000 years. A Norwich cohort of 93 patients also reported a 91.2% biventricular repair rate. This demonstrates marked improvement in outcomes of DORV surgery, especially the rate of biventricular repair. However, the choice between biventricular repair and single ventricle palliation for NC-VSD remains debated among demounted countries. The Fontan procedure offers relative technical simplicity and better perioperative safety, but carries risks of long-term complications and Fontan failure. Biventricular repair restores normal physiology and promises better long-term quality of life, but is technically demanding with higher early mortality and intervention rate. AAPCHS Hospital in Toronto compared outcomes for biventricular and Fontan palliation in the NC DORV. They suggest caution. They suggest caution selection for biventricular repair due to high early mortality and interventional risks. Commercially, full-wide hospitals especially indicate that most of the selected patients with NC-VSD can undergo successful biventricular repair with satisfactory results. Now, let me show our center's experience over the past 20 years. From 2005 year to 2024 year, we performed surgery on 1,329 DORV patients. This shows the annual case volume and the distribution of subtypes. Recent years saw a decrease, likely due to declining birth rate and advanced prenatal diagnosis. The subtype described was VSD type 49.8%, TLF type 29.6%, TJ type 4.1%, and NC type was about 16.4%. We separated our dates into 2 parents. In 2005 year to 2014 year, there were 598 cases. This overall biological repair rate was 85.6%. Primary repair rate was 40.4%. Staged repair was 15.2%, and the Fontan operator accounts for 14.4%. In the decade from 2014 year to 2024 year, we can see the biological repair rate increased to 98.5%, primary repair rate up to 87.7%, staged repair was 10.8%, and Fontan operation just about 1.5%. Further confirmed the 10-year outcomes, we can also see between the areas over survival improved from 86.3% to 92.5%, and fluid flow reinterventional improved from 80.2% to 89.9%. The improvement was seen across all the strategic groups. Now we can see, focusing on the 218 NCVSD cases, the biological repair rate increased dramatically from 61.7% to 92.7%, while the Fontan rate dropped from 38.3% to 9.3%. Large improvement could see in the biological rate. For long-term outcomes, 10-year survival also can see for the NCVSD patients improved from 99.3% to 80.1%, and fluid flow interventional from 70.7% to 86.4%. Among the biological repairs for NCVSD, there were 32 cases undergo staged repair. This was most for infants about less than 3 months, and suitable for immediate anatomical repair, or older children above 4 years who had palliation like gland. On the one hand, staging allows simultaneous review and promote ventricle or pulmonary arterial growth. On the other hand, use advanced assessment techniques like 3D printing before the second stage help selection patients suitable for the conversion to biventricular circulation, especially for those with Fontan high risks, such as main pulmonary arterial pressure over 20, moderate to several AV valve regurgitation, nectar index less than 250, and or LVT obstruction about 30. These patients need thorough evaluation for biological repair feasibility. We utilize 3D printed heart models to assess the VSD arterial relationship and left ventricle volume, aiding perioperative planning. Generally, we consider biventricular repair feasible if an interventional battle can relieve tunnel to the VSD to the aorta, and the left ventricle size is near normal. Now, for the discussion points, biventricular repair is the preferred goal for the DORV. However, the debate still between the whether choose primary repair or the staged repair. In these cases, such as VSD type or TORV type or TJ type, the timing and the technical for primary repair were well established. But however, for NCVSD, all the patients are suitable for primary repair. Feasible depends on the specific anatomic and surgical experience. The key of the anatomical repair is creating a non-obstructed ventricular tunnel, such as technicals including in small infants using long-term to connect the VSD to the aorta, or in the older children, some centers reported using artificial conduit technicals. Well, the primary goal is to establish an obstacle tunnel from VSD to aorta. Factors influencing this includes the distance between the tricuspid and the pulmonary valves, VSD size and location, spatial relationship of VSD to the outflow tracts, VSD balance, and the degree of AV valve override. Weak inside primary repair suitable if a non-obstructive tunnel is feasible. Ventricles are balanced and there is no AV valve override. But for the staged repair, is advised if initial tunnel creation is impossible, there is mild AV valve override, borderline ventricular imbalance, first evaluation less than 6 months old. Then we can see in the Boston experience, they showed that staged repair is a valid strategy in select complex cases, with outcomes comparable to the primary repair. However, the optimal age for primary biventricular repair remains controversial in different hospitals. For the Boston experience, they suggest that debated by the anatomy, infant or 1 year old. But in full experience, they suggest that over 3 months old, all the selected patients can accept the biventricular repair. And in other China center, they suggest that the optical age is over 2 years. But in our hospital, we suggest that if patients over 6 months old, these patients could for the primary biventricular repair. And in addition, plasticity assessment techniques like 3D printing can significantly increase biventricular repair rates. However, the Fontan placenta retains a law for selection cases with significant ventricular imbalance or several AV valve override. A balance must be struck between its earlier benefit or the light and the long-term risks. In centers with less experience, where biventricular repair carries higher risk, Fontan may be the safer choice. And we think surgical safety must always be paramount. So, in summary, our center's strategy for DORV is for VSD type primary repair in neonates or in infants, and for TORV type anatomic repair after 3 months of age. For TJ type, repair strategy based on the presence of PS. And for the NCVSD type, we strategize by anatomic complexity. For the mind complexity, we do primary repair typically over 6 months. And for the moderate complexity, we do strategic repair. However, for the several complexities with no feasible tunnel, we recommend Fontan prudence. Overall, given the high anatomical variety of DORV, individual surgical plans should be performed, and biventricular repair as the first choice. Second, process evaluation based on 3D printing and perioperative simulation can effectively improve the anatomical collection of rate of NC type. Second, in case of complex anatomy and insufficient experience, Fontan procedure is preferred. Well, before the conclusion, allow me briefly introduce my hospital. Our hospital was jointly established by the Shanghai municipal government and Project Hope, and now is a National Children's Medical Center with 2 campuses. We oversee 4 regional medical centers and dozens of provincial hospitals, serving a population of about 15% to 20% of China's total population. Our heart center is a leading pediatric cardiac surgery center in China, performing over 3,700 operations annually, with complex cases exceeding 60%. Our overall success rate is over 98.5%. Under the leadership of Professor Zhang and Professor Chen, we continue to strive for the excellent. Thank you for the attention. Thank you.
Thank you. Thank you very much. And in the interest of time, we need to move to the next speaker. And I would like to urge